But first off, thank you all so much for joining. We're super excited for our fall set of seminars here and so delighted to have Dr. McCradden here to kick us off. Just to introduce her a little bit, Dr. McCradden is a bioethicist with the Department of Bioethics in the Hospital for Sick Children. Just a reminder for folks who are joining online, please mute yourselves so we don't get any background noise and can make sure we have our speaker here. Perfect. So Dr. McCradden is a bioethicist with the Department of Bioethics in the Hospital for Sick Children, SickKids, providing clinical and organizational ethics consultations, policy, and education in bioethics. She is the John and Melinda Thompson Director of Artificial Intelligence in Medicine, AIM, where she is the integration lead for AIM. Dr. McCradden is also an associate scientist with the Genetics and Genome Biology program at SickKids and an assistant professor with the University of Toronto, Dalla Lana School of Public Health. And without further ado, I'm going to hand it over to you.
Awesome. Thank you so much. Thank you for the invitation to have me present today. So I am going to be talking about our fairness policy at the Hospital for Sick Children. There's no specific grant funding to disclose, but we do tend to acknowledge the traditional territory to which I'm coming to you from today. Today I'm coming from Toronto in Ontario, Canada, which is the traditional home of the Huron-Wendat, Seneca, Petun First Nations, and the Mississaugas of the Credit River. One of the important things for us from an equity consideration is to think about how everything that we do impacts the original caretakers of this land. And so this work that I'm talking about today incorporates their views, and they have participated and helped us with this policy to try and prioritize equity. So the way I want to start today is to give you a case, which I know is a little bit different to what many people might be familiar with the research talk. But generally, when we're talking about ethics, we find that using cases really helps us contextualize some of the issues. So I'm going to talk to you about Abby, who is a patient at SickKids. She's 14 years old. She needs a kidney transplant, but she's got a lot of medical complexities. She's been on dialysis for many years. She could potentially live for much longer on dialysis alone. However, dialysis is burdensome. You have to come to the hospital multiple times a week, and it also has some risks as well. Now, a kidney transplant would replace the need for dialysis, but that also has risks. Abby's risks might be higher given her medical complexity. So what I want us to think about today is that we could use a model in many different contexts within the Abby's care journey. So we could have a model that might predict Abby's chances of a successful transplant, meaning no postoperative infection, her body accepts the new organ. We could have a model that prioritizes Abby on the list for transplant, so assisting with prioritization and triaging of patients within the transplant list. Or we could have a model that gets Abby access to a complex care management program to support her care for dialysis and potentially transplant. So what I want you to kind of ask yourself today is what's fair from a model perspective the same in each of these cases? Or whether we might need different ways of contextualizing fairness given the different use cases for machine learning. Who decides what's fair, and how do we decide what's fair? So what we've done is tried to embed justice across the machine learning lifecycle so that wherever developers are coming into contact with machine learning applications that could inform the care of patients, that they're enabled with some of the tools to kind of work through this on an ethical perspective. So I'll talk a little bit about the problem of bias within the context of clinical machine learning applications. I will introduce the JustEFAB framework and focus on ethical decision-making. And then I'll talk particularly about the role of the silent trial, which I see as an increasingly important tool that we have in the evaluation of clinical machine learning systems. So I think most people are familiar with this paper by this point. This was the very famous case of an algorithm used in the United States to automatically refer patients into a beneficial complex care management program. Ziad Obermeyer and colleagues explored the decisions that were being made by and with the algorithm and found that patients who are Black were twice as sick as patients who are white at the point when they were being automatically referred into this care management program. Dr. Ruha Benjamin has a very revealing commentary where she points out that many of the patterns that are embedded within medicine more broadly, so issues of access, issues of outcomes, issues of the experiences that different patients have, can become embedded into our algorithms, into our data, in ways that recapitulate these same patterns as we move forward. Now, one of my favorite papers on this is actually by Columbia professor, Dr. Shamali Joshi, where she and her colleagues have developed this really nice framework for how you look at machine learning bias. One of the things that I think has been a limitation for a long time was that people thought of it as an issue of representation. So we just need more examples for machine learning and our systems will improve. And in many ways, the accuracy can, in fact, improve with better representation, but that doesn't necessarily mean with better fairness properties. So they point out that a lot of the things that we look at and that we evaluate are sort of the tip of the iceberg issues. So we can see them, we can measure them. However, what we don't often perceive are all of the issues below the surface. Many things that are both structural, social, and data-based that influence the performance of these machine learning systems in a healthcare context. So I'll dig into a couple of those, starting with problem selection. So one of the issues that we face is that for a long time, the kind of narrative within science has been that science is not political, it's neutral, it's objective, we only study what's in front of us. However, we also know that there's worldwide disparities in the study and funding of health research. So which problems are selected for funding and who gets more funding? We know that there's a current gap for health among citizens of the global south. There's relatively lesser exploration of poverty-related diseases, exploration within racialized groups. Women's health has been underfunded for a long time, and mental health as well, carrying that stigma. So what this amounts to is that some problems are better funded, studied, and understood than others. This then translates into data. So how much data we have to represent different medical phenomena is influenced by these issues. There can be issues of data quality. So how mature a health system might be in terms of collecting data on patients, what modalities that data might come in, and the sources of data as well. So this is a review of data sets that were used to develop ophthalmological machine learning solutions. And you can see there the relative contributions of data sets across different countries. And so again, we see that there's a very large disparity in terms of who gets represented within these data sets. Another one of the issues that Chen and colleagues point to is outcome definition. So when we're selecting our labels, they point out that there's an issue of noise. So many times, these labels are not a pure capture of a medical phenomenon. So you can look at this by kind of contrasting, for example, if you were looking at an EEG, some sort of measurement of wave activity, we can quantify fairly reliably what a particular spike might look like, and we can categorize that spike. When we're talking about things, however, like how advanced is someone's kidney disease, or do they have schizophrenia or not? There can be more or less influence that comes into how we define those labels and who gets attributed those labels. They also reflect the current state of knowledge on a topic. So even in the course of my own career, I started in a PhD in neuroscience. And one of the issues that I studied was the phenomenon which was known as conversion disorder. So this is a phenomenon whereby someone will have what is a very apparent neurological phenomenon. However, it's not a matter of psychological influence. People can really feel that they are paralyzed or that they cannot see. And so even over the course of my career, this has become known as functional neurological symptom disorder, in the recognition that there's actually consistent and clear patterns of brain activity that are associated with the symptoms previously known as conversion disorder. And this happens for many other issues as well. There's some subjectivity even among relatively obvious and clear phenomena. So even when we are encoding waveform activity, there are some that are really clear and consistent. There's others where there's some judgment required in annotating the specific phenomenon. Additionally, they're affected by social climate, policy, and law. So, for example, homosexuality was part of the diagnostic statistical manuals for mental health disorders until not that long ago. There was also a term for persons who were enslaved, who had escaped, called drapetomania. This was a medical diagnosis. The law also changes things as well. So when we have policy changes, for example, when it comes to age, we change the age at which we might diagnose individuals. We also find that among vulnerable groups, there's both under and over diagnosis, which means that you have opposite problems within the context of the same machine learning solution. And so knowing which way it should be going is a challenging one. There's also differences along racial and gender lines, which are not indexed to clinical presentation when we are attributing labels. They can be related to social attitudes, but they can also be propagated through formal and informal medical education. One of the common examples is the belief that certain racial groups are less likely to experience as severe pain as others. That's something that still exists within certain medical textbooks. So when we're talking about algorithms and we're linking these data into some defined outcome, we know that they're not neutral. They represent our current state of knowledge on a topic. We've also seen that particular model choices can put patients at different levels of risk. One of the examples in that study by Obermeyer was that they thought that they were using an objective label by looking at the amount of healthcare expenditure as a proxy for how much healthcare needs someone had. They also removed race as an identifier, thinking that that would make the algorithm neutral, which we now know is not something that people typically think has validity from a science perspective. There's also a lot of associationist thinking that we have to think about because machine learning is an associationist methodology. So when we see really stable and replicable patterns within data, we have to think whether that's causally related or not. Might there be structural influences that are making those patterns apparent, or what is the influence that's resulting in that pattern? And then there's algorithm fairness, which is a set of tools and different methodologies that one can use to explore the different fairness properties of a given system. So for example, we can test whether if we remove a particular identifier, what influence that might have on the predictions. We can explore the different model design choices to hypothesize about what kinds of outcomes we might be able to effectuate. And I'll talk about that a little bit more when it comes to our guideline development. And then finally, Chen and colleagues identify the post-deployment issues. So once we've made a model that has satisfied some definition of fairness, there can also be latent biases. So there might be changes introduced by the model's use. So for example, practice shift patterns can happen. And then we also have the issue of data set shift. So when we see that the features of data might change over time, there can be changes to the model performance. And post-deployment monitoring is something that is an ongoing issue for many health systems. So there are some emerging practices around how to evaluate for these performance shifts. However, to the best of my knowledge, many of them don't actually incorporate fairness-based assessments into these formal institutional review processes. So coming back to algorithm fairness for a second, one of the challenges that we've seen in this space is that we can have a model that meets some definition of fairness, which typically, might be loss of accuracy or equalized error rates or other sorts of technical definitions. And generally, they're bracketed into these three different types. So we could have data-based methodologies where we're changing the data, increasing representation. We might have model-based methods, so exploring different methodologies for predictions, or post hoc methods like threshold setting. So what we've kind of done is looked at these different methodologies and tried to link them to some fairness objective. And this is what we did with my colleague Shamali Joshi, where we explored the potential link between these technical definitions and a real-world outcome. And what we identified is that really whether or not you can affect change through algorithms is going to be constrained, first of all, by what we know about the causal nature of the unfairness pattern. So if we look back to the Obermeyer paper as an example, because the team developing the algorithm didn't know that simply removing the racial identity of patients would not resolve the larger structural issues that resulted in the patterns that were embedded within the data that trained the algorithm, they weren't able to make a change in terms of reducing a healthcare inequity. So what we know about why those patterns are present will tell us something about whether or not we can make different model choices or different database choices in order to try and address that change. The second thing we need to know is how we're going to evaluate the model's real-world performance. So very often what we see is teams will look at the prospective performance of a model in terms of its accuracy values, positive predictive values, negative predictive values, etc. But the gap that we see is that this is characterizing the model performance, which is helpful and important. But we also need to go a step further in terms of measuring the impact of patient care, because a couple of publications have demonstrated that we can have a model that performs well, but unless it's linked with a specific action to help a patient, it may have limited effect. So how we make that decision has to be guided by the desired intent of the model's use at the point of care and linked with accountability mechanisms. So the way that we do post-deployment surveillance, we can look at different groups and the impact on different patient groups. Now, this is important because models ideally should improve care. We hear a lot about augmenting physicians, but ideally what we're actually doing is augmenting care, ideally reducing health inequities. And so what's fair for Abby will depend on the specific task that the model is going to perform and the nature of the health inequity we're trying to address. So how should we go about thinking this through? We used as inspiration this quote from Dr. Benjamin, which is, if inequity is woven into the very fabric of society, then each twist, coil, and code is a chance for us to wave new patterns, practices, and politic. Its vastness will be its undoing once we accept that we are pattern makers. So one of the first steps that we have to take is by developing a policy that addresses all machine learning tools across the hospital, not simply the ones that we think are at risk, because we are intending to try and weave these new patterns. So justice, equity, fairness, and anti-bias at SickKids is the policy that we've implemented. And it really is a guideline that's intended to help identify, analyze, and address issues of algorithmic bias across the life cycle of machine learning development and deployment. It draws heavily from its predecessors. So for example, the Algorithmic Bias Playbook was a strong influence to us, as well as the NIST standards. But we've tried to take the step going beyond technical performance and measuring the model in terms of linking it with those real-world actions. In doing so, we've prioritized the medical ethics principles that are core commitments within our healthcare system, as well as social justice as additional commitments across the machine learning lifecycle. The framework is also generalizable across contexts by being inclusive to non-Western ethical frameworks. And we really relied a lot on our coworkers for helping us stay out of solely the Western space and thinking more broadly about how fairness might be defined in other contexts as well. So JustEFAB is guided by what's called standpoint epistemology. So this is a feminist philosophy of science that has advocated that the quality of science improves with multiple standpoints. So this is the idea that individuals coming from different lived experiences, different disciplinary backgrounds, working together can enhance the quality of science. And they really push for the fact that it's not just about kind of being nice people and including others in our decision-making. It's really about doing better science, better quality, and more rigor. These standpoints reflect different ways of knowing. So this can be disciplinary, whether you are in ethics, for example, or machine learning, or statistics, or implementation science. They are different ways of knowing, and that also includes lived experience. So our patients, our families, our data clerks, our front desk workers, they're all individuals who have a piece of knowledge relevant to the implementation of machine learning models. And so in this way, feminist epistemologists view knowledge as a social product. It's something that we collaboratively develop together. And so for JustEFAB, what it means is the decision about what should be done to promote justice with the use of machine learning tools is a matter of more than just the actuarial performance of the system and requires an epistemology-like standpoint theory for ethical defensibility. And this is linked with many folks who are advocating for the view of machine learning models as socio-technical interventions rather than a technical product, the way that, for example, a calculator might be. So we developed JustEFAB over the course of a number of years. Initially, it is intended to be an organizational policy. However, as I said, we did some external generalizability testing across other countries and health systems. At SickKids, we mapped this onto our clinical integration policy. For all machine learning solutions at SickKids, they undergo a design and development stage, a silent trial stage, and then a prospective evaluation, as well as ongoing safety monitoring. So the overall guideline was developed through many years of ethics consults. So teams coming to myself and the AI group at SickKids at different stages of model development in different contexts using different methodologies. And so over the course of those years, we refined this with support from our colleagues and feedback from users. We then trialed it for feedback and made modifications based on consultations with equity deserving groups at SickKids. So I have the full list at the end of the slides, but what this involved was myself and my colleagues going around to the different groups at SickKids, and we're very fortunate to have a robust equity, diversity, and inclusion strategy at the hospital. So this included our Indigenous Health Council, the Gender Clinic at SickKids, 2S LGBTQIA+ Committee, Women in Science, Black Student Caucus, Black Students for Public Health, and a number of other groups at the hospital. So as I said, the clinical integration guideline really reflects these 4 stages, and so does JustEFAB. So in the initial stage, when we're designing and developing models, JustEFAB will point us to the identification and exploration of algorithmic bias patterns and identify potential mitigation strategies. During the silent trial stage, we want to verify our assumptions of stage 1, and we test on-the-ground performance. We also integrate EDI considerations into complementary evaluative strategies like human factors analysis. In the prospective stage, we want to look to inclusive recruitment practices, identifying opportunities for representation to enhance participation, to establish performance across subgroups. And then, of course, we want to do ongoing monitoring for relevant patient subgroups. So I'm going to break down each of those stages into the specific components. But I really want to identify one of the issues, which is the ethical decision-making aspect of this. So just in looking to the first stages of the framework, which are relating to the design and development stages, initially we have preparation and conceptualization. So this first part will be familiar to anybody who works in algorithmic fairness, I think, especially if you've worked with the algorithmic bias playbook. So that first step really is about literature review and consultation. So based on knowledge of the literature and the health problem being addressed, we can identify specific groups who we think are going to be likely to be at risk of a health disparity and potentially at risk for algorithmic bias. One of the challenges that we have, particularly in Canada, is that for most health systems, if not all, we do not routinely collect race and ethnicity data on our patients, which is a very big problem from a bias assessment perspective. So what we've had to do is use sort of creative methods of identifying patients who might be vulnerable. So for example, we can use a subset of the postal code linked with census data to identify what neighborhoods a child might be from in order to assess their potential vulnerability to structural health determinants. So problem formulation, again, is something that has really kind of gained in notoriety since the Otto-Remeyer's paper. And so with consultation from other groups, for example, our equity-seeking groups, we can identify what problem is more or less likely to improve a health disparity. So are there different ways of thinking about the task that the model performs and what data sources might underpin that task performance so that we can try and improve health inequities. Once we sort of have that idea of who are the vulnerable groups, we want to look to the inclusivity parameters of the data set. So knowing what inputs we have. As I said, we don't routinely collect race or ethnicity data. So we have to think carefully about the representation and labels that we have access to in order to try and do some fairness assessments. We also encourage teams to engage in data set reflexivity. So thinking about how people are captured within within the data that underpins machine learning systems. So one example of that is actually a series of questions that you can pose to, for example, a unit clerk, who is the person who is registering patients when they come into a particular unit. One of the things that revealed is that when people are entering gender into our health record, there are some people who will look at the patient and enter what gender they think that patient is into the health record, whereas other people will either ask the patient directly or will use what's on the health card. So one of the risks that we can identify from that practice and speaking with the people who are entering the data is that our information about patient gender may not be all that reliable. So given this set of information, we can now come up with an analytic plan. That analytic plan forms the basis for our algorithmic validation. So exploring the fairness distribution of the candidate model. So we test and compare performance among subgroups. We use algorithmic fairness methods. And so through this, we can kind of query the model's performance at a broad level to try and identify what potential strategies could be used. We also want to test for post hoc grouping. So this is known as hidden stratification. So might there be clinically relevant subgroups where the performance drops off that we need to be aware of? All of this information forms the empirical foundation for our ethical decision-making step. So if we walk through kind of the process of ethical decision-making, which I'll do with respect to Abby's case, what we want to do is we want to gather the information, gather the perspectives of stakeholders, identify the potential risks, so i.e. the biases in this case. We'll talk a little bit more about reflective equilibrium, which is reflecting on different strategies that we might use, the potential consequences of each of those. And in the end, we have to select a prioritized value. So I'll show you a little bit about how that works. So coming back to Abby's case, as I said, we're trying to predict Abby's chances of having a successful transplant in one scenario. Another might be to prioritize Abby on the wait list for transplant. Another might be referring Abby to specialist care for her medical complexity. So let's start with the first one. The first one, predicting Abby's response, really is a question of prognosis. So whenever we have a medical intervention, there are risks and benefits. What we know is that some of these risks can be well known and well characterized. Others might be less well known. So for example, we know post-op infection might be more likely if you have less good of a match when you're performing a transplant. However, others might be less well known. So for example, we know that social and structural health determinants influence patient outcomes among vulnerable groups in ways that we don't fully appreciate and can't fully quantify. So these forms of bias can shape the patterns embedded in the data. So we know that more representation from someone like Abby, who might be part of a marginalized group, is not necessarily going to help us, because if they all have worse outcomes by virtue of these other determinants, that poses challenges from a representation perspective. So what we want to know is, are some of these potentially modifiable or non-modifiable? Again, as an example, sometimes patients have difficulty with adhering to a treatment regimen, particularly with dialysis, where people can have really big issues of access. You might have issues of caregiver income trying to support the care of a medically complex child. Some of these might be modifiable, where we can identify social supports for parents, whether it is engaging at-home nursing care or providing taxi vouchers to the hospital. There's a number of things that we can potentially do that might make Abby's clinical status improve such that she's a better candidate for transplant. However, there's also non-modifiable factors as well. So some of Abby's pre-existing health conditions might not be modifiable. They might simply be factors that influence her prognosis. Overall, medical recommendations are made on the basis of a patient's best interests. So this is where we have to consider the balance of benefits to harms, the available alternatives, and the likely consequences. And then what is best and what's potentially within a range of better to worse. So this is really fundamentally an individual decision-making paradigm that also takes into account Abby's perspective and her parents' perspective. So sometimes we have something where it's very straightforward and medically what's best is what needs to be done. There's other cases like dialysis where there are risks and harms in two different directions. And so we have to consider Abby's unique context. Now, depending on where you live, Abby's wishes might or might not be determinative. So for example, if you live in Ontario where we have no age of capacity, if Abby is capable, i.e. she demonstrates understanding and appreciation of the relevant risks and benefits, the potential alternatives and the consequences, Abby would be the one who's making the decision about whether or not she receives a transplant on the basis of knowing those risks and benefits. In other jurisdictions, Abby might or might not be a mature minor, so she might be over the age of 14, for example, if she lived in Quebec, and she would be entitled to the decision. In the United States, more often, it is about parental authority, so Abby's wishes would be taken into account by her parents, but ultimately her parents would be the responsible decision makers. So when we put all this together, let's say we had a machine learning model that was going to predict Abby's prognosis, we might see within the patterns that there are influences on its predictions such that Abby might be given a more negative prediction compared with, for example, someone who had the similar clinical features, but was more socially advantaged. However, we've got to look at Abby right in front of us. And so our advice might be that fairness in this case is providing the most accurate information to the clinician. So our value that we might prioritize here is predictive accuracy. So we say potentially there are biases influencing Abby's chances at having a successful transplant, but ultimately we need to give the correct information to Abby's family to make an informed decision. So that's one example of a value that we might prioritize identified by JustEFAB. In contrast, let's look at transplant listing. So it's important to say transplant ethics is an entire field of study that I am attempting to kind of quickly summarize here. But generally, across the world, transplant prioritization reflects a certain stage of the disease where a transplant is warranted. It will reflect medical criteria about a patient's current functionality or limitations. They tend to incorporate psychosocial considerations, which again is a topic of a lot of study within ethics. So for example, if you're a candidate for a liver transplant, how long might someone have to abstain from alcohol in order to be a candidate? Similarly with use of illicit substances. There's also a major issue with respect to adherence or compliance with medication provision that has a lot of implications for bias. Additionally, they look at relevant comorbidities or other impacting factors. So anything that might suggest that there's more harms than benefits that will affect someone's status on the transplant list. But overall, what it comes down to is you need a good match. That's an organ. They look at urgency, so more urgent equals higher priority, and then prognosis. So better prognosis equals better priority within a certain subset. So if we were looking at a machine learning model that was looking to perform the task of allocating people within the transplant, predictive accuracy might not be the best option because we're not just prioritizing something like prognosis. We're not necessarily looking at outcomes. We might be saying instead that patients with similar medical considerations should be prioritized similarly, where someone has more potential for benefit, they would be prioritized differently from someone who has less potential for benefit, or someone with a greater match in terms of an organ would be prioritized differently from someone with a lesser match. So in this case, we might say that our machine learning model is prioritizing formal justice or equality. So all patients should be treated the same, given similar medical considerations. Now, in the third example, we can look at specialist referral. So Abby might benefit from specialist care given her medical complexities. A specialist can provide individualized treatments. They can understand the unique context of the patient. And because of this, they can be better advocates for what a patient might need. We know from the literature that many groups of patients are under-referred for specialist care, whether that's by virtue of their geographic location, by virtue of whether or not the referring clinician believes that they will attend the appointment, and sometimes it can be issues of medical prejudice. So patients who have been disadvantaged by the medical system often wait longer or are in worse health when they finally get care. And so people have hypothesized that if we refer such patients earlier, we might potentially improve outcomes. So if we think about Abby at the point where she is in care, if we were to refer a patient like Abby who might be disadvantaged earlier than we typically would for other patients, might that help address a health inequity? And so if we were to do that, addressing an inequity through a prioritized referral process, we would say that we're prioritizing distributive justice or equity. So what we can see here through these different cases is what we might decide as fair, and certainly there's people who might disagree with what I've said here, but what we've decided is fair in each of these individual contexts is really linked to the specific model that the task is performing and what effect we're trying to have on Abby and patients like Abby as individuals and groups. So the way that we do our ethical analysis incorporates our medical knowledge, so knowledge of patients with transplants and the consequences, the lived experience, so what it's like for patients like Abby and how they access healthcare, and knowledge of health inequities. So why is this potentially happening? Why are these patterns apparent in machine learning models? We couple that with empirical evidence from the model's performance with respect to different groups of patients. So in each of these cases, we would look at how a model performs and assess whether our choice of value is actually going to be effective, given the design choices we've made to the algorithm. And in our ethical analysis, we're looking at different stakeholders. So you might look at this from the perspective of Abby, of her parents, of the healthcare system, of the clinician who is providing care, of the transplant listing service, for example. We put together all of our information and we reflect on different choices. Once we select an option, then we act and we revise as necessary. And that's what comes into the second stage here of the JustEFAB framework. So the silent trial and clinical validation of fairness means that we're looking at the clinical performance. So the silent trial is where we implement a model in a clinical setting, but without the predictions reaching the treating team. So the predictions are kept on basically silent mode, where they go to the research team, who then assesses them against the ground truth. So in a example like Abby's, what we would do is we would assess the predictions being made for incoming patients. The research team would then collect those predictions and assess them against what actually happened to the patient in order to establish some clinical accuracy. We then want to characterize the performance across relevant subgroups. So because this is only descriptive at this stage, we would be hypothesizing about it. So let's say we were running a model that was designed to prioritize at-risk children earlier into a specialist care program. What we would do is we would see at what point they're interacting with the healthcare system, making sure that the prediction is in fact reflecting the kinds of patients that we want to prioritize, and then hypothesizing about how early they could have received care. Once we think that we have a mature model that meets some definition of prospective performance, we would perform an audit to explore for failure cases, make sure we have a really comprehensive understanding of the model as a whole. And potentially this is where we'd be open to revision. Let's say some of the assumptions that underpinned our choices about fairness methods don't actually hold up in a prospective environment. We might go back and revise them. One of the other things that JustEFAB points to is how human factors principles also impact the overall fairness of a model. So for example, human-centered design is a very big area of study where we're thinking about how to best have interactions between computer-based systems and individuals. We also think about respect for persons as one of the core principles here. So we know that clinical teams have very, very heavy workloads. They have values-based commitments to their patients. And so by prioritizing their involvement in the machine learning integration lifecycle at specific points, we can best involve them and get their say into how models should and should not be implemented. And this comes up a lot as well in terms of what language gets represented with machine learning systems. So again, as an example, let's say we had a model that was designed to predict whether someone did or did not have a genetic disorder. One of the things that's been brought up from our patient groups is that when your predictions reflect either, has genetic disorder or healthy, it gives kind of a stigmatizing view of individuals and their relationship with healthcare, because we can have people who have genetic disorders who are quite healthy. Similar things come up in terms of bias assessment. So one of the ones that happen for us is that we want to support support families who might be at high need of personalized interventions to help them attend healthcare appointments on time. And so the language that we use in explaining to a family why we've identified them as being at risk can be incredibly important, because it can either be further alienating to that family, or it can be supportive and affirming. So digging into the silent trial a little bit more and its role within health justice, I think kind of reflects where we are in our current understanding of how to evaluate machine learning systems. So we have a lot in terms of the responsible machine learning guidance. So for example, the FDA and Health Canada have good machine learning practices, the NICE standards for digital health technologies, and the World Health Organization's emerging clinical evaluation guidance. So there's a lot about making a good model. We also have a lot about clinical trials now. So DECIDE AI is the first in human testing reporting guideline. We have Spirit AI, which is for reporting on clinical trial protocols involving AI, and then Consort AI for clinical trial reports once you've completed the trial. We also have more about post-integration monitoring, so looking for issues of dataset shift. However, there's a gap in between responsible machine learning and clinical trials, which people typically will use a silent trial to do some sort of validation. And I think there's actually a lot of room for expanding what we think about during a silent trial. So in terms of the goals of a silent trial, one of them is to assess that the model is going to continue having some measure of prospective performance in a live setting. And so one of the things that we might look for are establishing facts about the distribution of benefits and burdens of a given system. So how is it performing across different subgroups? We can then compare that subgroup performance across multiple metrics, whether it's accuracy or error rate or other methods. We can also do reverse prediction to identify a potential signal. So this references to the paper that many folks might be familiar with, where a number of researchers identified that you could train AI to trivially detect patient race on the basis of images alone in a healthcare context. And so this is one of the things where, to my understanding, we're still sort of exploring how universal is that phenomenon? Does this happen for example, ultrasound images? And what is the potential significance of it on a model performance perspective? We can also do a lot more in terms of looking at failure cases. So there was a really interesting paper recently about qualitative exploration of failure cases. And we actually did this at our hospital with one of the models that's currently in a silent trial, where we were looking at the fact that it was underperforming relative to patients who spoke specific languages where we didn't often have translators present. And so there were a number of reasons why that pattern might be present. In some cases, we have folks coming from other countries or people who might be undocumented immigrants who either aren't sure or don't have access to healthcare insurance. And so you might do fewer tests in order to not charge the family for something. They might not stay for the appointment. Sometimes people might leave if they're fearful of receiving, a large healthcare bill. Or it can be an issue of data quality. Potentially there's something different about the data for these families. And so what we ended up doing was exploring those particular failure cases for those individuals. And we found that because there wasn't the ability to access translation-based services, there were far fewer data points, so less triage notes, some inputs that weren't collected by the person at the point of triage. And so that was really likely to be the thing that was causing models to underperform. The other issue is the medical algorithmic audit, which is a Lancet Digital Health paper, which is increasingly emerging as a tool to more reliably characterize model performance. And so this is really what we need to rely on, because we can speculate about the potential impacts to different groups, but really we need some information to help us make the decision about what we should do about it. And so there's a few ethical principles that come into play when we're doing this, and one is accountability. Doing a silent trial when you're testing a model, or even if you're purchasing a model from an external source or external vendor, can protect patient interests, because we know that many models, there might be different definitions of fairness, there might be different representations. So again, if you were going from a US context to a Canadian context, how the model might have incorporated patient identity might look differently. And really doing this guards against AI failures. And we know that particular groups are more likely to be at risk of AI failures than others. And so it's a key step in accountable organizations. There's also community relevance. So this was one of the insights, particularly from our colleagues in different African countries, which is that the silent trial offers this ability to tailor the local workflow and incorporate user characteristics and values. So many individuals kind of pointed out that who you might link to by virtue of an AI prediction might be different in different contexts. There's also how you speak with people about the impact of the machine learning tool. And so we can incorporate things like human factors analysis specific to the workflow at that point. And then ethics offers kind of a structure for using this knowledge to make decisions that will advance the interests of patients who are experiencing a relative disadvantage. Once we've passed that silent trial stage, then we're moving into prospective clinical evaluation. So from an ethics perspective, we of course look at diversity in terms of clinical trial participation. However, some folks have highlighted that we need to be very careful about what we're talking about when we're saying why diversity is important. So there's a history of belief that there are physiological or biological differences between races. However, we know that generally this is debunked. However, there might be differences with respect to specific kinds of applications. So for example, the pharmacodynamics might be different depending on circulating hormones within different individuals. Those might not directly be indexed to gender or sex or other ways. And so really we need to think about what we're measuring and why we're measuring it and how we're measuring it. The other aspect from an equity perspective is consent considerations. So people will point out that there is an apparent difference in the rate of participation in clinical trials between, for example, Black and white patients. However, other studies have pointed out that this might be largely accounted for by the fact that white families or patients are much more likely to be approached about research participation compared with families who are Black. And so we're actually having a bit of a self-selection bias in terms of that research participation. Additionally, when we look at recruiting materials, who gets represented on, for example, study flyers or study posters, that also affects who's likely to participate. And many colleagues within our equity deserving groups at SickKids had pointed out that one of the large reasons for distrust in medical institutions relates to previous examples of where consent was overridden. And so when we're talking about using a machine learning model that will change or affect someone's care journey, consent becomes more important in terms of promoting equity within the evaluation of these tools. Finally, we need to think about the comparison to the status quo. And this was particularly sparked by a study by Emma Pearson and colleagues, where they demonstrated that an algorithmic assessment of knee pain severity was actually superior from a fairness perspective to a clinician-based assessment of knee pain severity when comparing Black and white patients. And so if we were simply to compare the algorithm to the current standard, we might be measuring against a bias, and that might not effectuate a health inequity. So we have to really carefully look at what we're comparing it to, and again, looking toward those patient outcomes to try and assess whether or not and how we're improving a health disparity for a marginalized group. And then finally, we come back to the oversight and monitoring. So once we have a system that we have evaluated and demonstrated to beneficially support care delivery, then institutions are required to take ownership over that performance and maintain an observation of how the model is performing. And so people have kind of pointed to there's different ways that we can link equity within patient safety mechanisms. So we can look at whether there's particular groups where the model's performance might tailor off, particular groups who are less likely to access healthcare, and other sorts of ways of trying to assess the overall distribution of benefits and burdens of the system. So overall, JustEFAB advocates for informed choices with respect to model design and validation that take into account these different standpoints. We look for empirical demonstration of the model performance coupled with on-the-ground evidence that the model can influence outcomes in the expected manner. And how outcomes should be influenced is subject to collaborative decision-making, should be guided by the views of those most marginalized. So who are we trying to improve care for, and how might we do that? Those individuals have insight into what will be effective or not. Ongoing performance must be monitored for patient safety. And I always kind of stress that health equity can't simply be achieved with machine learning because we need to link it with specific actions. But machine learning can nudge care toward equity by providing that demonstration of where our gaps might be. And so the goal is that this can encourage proactive ethical reflection about algorithm design, development, testing, and integration, and that it is part of broader efforts toward improving equity at SickKids and Health AI generally. So this is the list of amazing colleagues who have worked on this paper with me, including many that you may well know, as well as the groups who helped us with the validation of the guideline, and consultation is ongoing as we continue to iterate on this. And so I want to leave you with a few really key references here that have really been influential to me. One of which, and maybe most significantly, is Abiba Barani's paper on algorithmic injustice and a relational ethics approach in patterns. Dr. Benjamin is a thought leader in the space and has an incredible presentation on the value proposition of science. And my colleague at U of T, Dr. Shayan Gua, has pointed out how data science is typically very model-centered, but we need to be pushing the conversation in a different direction and looking toward outcomes. And so we hope that our guideline can be a step in that direction. So with that, I will say thank you very much. And these are my contact informations. I'm happy for folks to reach out, and I'm happy to take questions.
Thank you so much. There's a lot of virtual applause. If folks want to ask questions, if you could just raise your hand and we can facilitate the Q&A that way. I think we have a question from Tara, Opera, and then Bettina.
Hi, thank you so much for your talk. My question was about, I think the examples were really helpful that you gave for the 3 cases with Abby and how those kind of explain the way that the framework is used in practice. I was wondering if you could share more about the general framework for how you weigh the different considerations that were kind of posed in those examples and how they relate to one another. For example, with the kidney transplant case, I know there's sometimes a question about if equality is really the best fairness metrics to use, because what if there are populations that have been systematically disadvantaged in the healthcare system is more, I think distributive justice was the term used, more appropriate in that case to support those patients. So how are these different considerations weighed against each other? Are there questions or a rubric that are kind of supported by the framework?
Yeah, absolutely. That's such a good question and could probably be the topic of an entire ethics class. Because yeah, you're right to kind of point out that the weighing is the critical thing there, right? And so even across different health systems, how we weigh them might be slightly different. So the examples that I was drawing from, we have like a central body that allocates organs. And so, from their website, this is how they weigh the criteria, and they can break it down for you almost exactly. However, other people have pointed out that if we take a different lens on things, actually, there's a lot of problems with how we currently allocate organs. And so in fact, you might not want to kind of prioritize equality. You might want to actually prioritize equity in certain ways. And so there's the decision that's made about the algorithm as a whole and how it performs the prioritization criteria. And I think there's some folks in the US who are doing a lot of work on this. But one of the challenges with it is that because for something like transplant, the harms can be so significant that if we recommend a transplant for a patient who, for whatever set of reasons, might be unlikely to do really well, we can do a lot of harm. So, and particularly when you're talking about a scarce organ. So there's different ways that we have to kind of think about it, and it'll depend on the specific organ system. So for example, if you're looking at kidneys and you have a match from a family member, that's different to a patient who might be awaiting a heart transplant where someone has to die in order to provide that transplant. So there's a lot within the transplant literature on this. And usually if you look at the specific list, they can tell you a little bit about how you prioritize, and then you'll find a lot of writing from different ethicists who might advocate more strongly for one way versus another. And it continues to be kind of an ongoing topic of debate.
Thanks so much.
Opera, you want to go next?
Yeah, thank you so much for your talk. This was really interesting. I was wondering if you could talk a little bit more about, you talked about kind of trying to make sure that this framework generalizes beyond kind of just the Western perspective. And you talked a little bit about testing in other countries, but I was wondering if you could talk a little bit more about how you kind of try to create that more global generalizability.
Yeah, absolutely. So one of the criticisms about fairness, and actually bioethics just generally, is that it does tend to be dominated by a Western worldview where you have there's the 4 medical ethics principles: beneficence, non-maleficence, justice, and autonomy. And so in a Western context, typically, like, autonomy is a individual who makes a rational decision on the basis of benefits and risks. However, particularly, so my colleague Kagiso Ndolovu from Botswana had talked a lot about how, if you were using an AI-based system for skin cancer detection, for example, generally, you're not talking to one individual about the risks and benefits. It's an individual embedded within their family, where decisions are made more collaboratively, where there is a different role of physicians. So, in the US, sometimes, and even there's variability within physicians. So some physicians sort of take the position of, I'm just giving you all the information and you must decide. In pediatrics, particularly in like a neonatal context, clinicians will often take a bit more of a directive approach. So, they'll say, this is what I think is best for your child based on my experience. And then even within, the Botswanan context, depending on where that physician might be situated, they might take a stronger or lesser role in that decision-making picture. So one thing we really didn't want to do is sort of say, here's the 4 principles, that's how you decide it's fair. We've sort of said, if you're working within a more relational ethics or communitarian ethics or Ubuntu ethics, that you would apply your own ethical framework to how you navigate between this empirical demonstration of a model's performance and the outcome that you're trying to affect.
Yeah, thank you.
Awesome. I think we have time for maybe one more question, if that's okay. Bettina, do you want to go?
Yes, I thank you so much for your talk. And my question is actually kind of related to Apar's question regarding generalizability and global ethical considerations. And you've answered most of it, but I think I wonder what your thoughts are in how we can anticipate and adapt to the evolving ethical challenges in technology, based on this guideline.
Yeah, that's such a good question. Yeah, I think there's a very, very big scope, particularly relating to like data and how data is collected, how it is shared across context, how it is used. But I think one of the particular areas where I think we could go a lot further in a more generalizable way is by promoting kind of the use of silent trials locally. So even as I said, like my colleague Kagiso, one of the reasons that we had connected was actually that he was testing a system in Botswana. And the manufacturers of the system had said, it performs well on, people who are African American. And indeed it did. But the skin tone pigmentation among individuals designated as African American within the US was very different from the skin tone pigmentation among individuals living in Botswana. And so one of the things that the use of a silent trial potentially could have helped with is to verify the performance on the ground, where they would, and they certainly did, observe that it's actually not performing as well. And you have to give more examples of people with different levels of skin pigmentation in order to improve the performance of the system overall. So the silent trial is kind of my like interest right now, and I would love to see kind of an expansion of those practices around the world.
Thank you.
Wonderful. Thank you so much for such a wonderful talk, and really just kicking off this semester seminar series with like amazing work. So thank you so much again. A final round of applause for our speaker. I hope you're okay if people maybe reach out to you if they have more questions and get in touch. But thank you so much to everyone who attended, and thank you again, Dr. McCradden, for a wonderful talk.